and they're posted on our YouTube channel. Okay. All right, so tonight we're doing GI, and I have several questions embedded. Most are multiple choice questions, but I have a few other questions. So you might want to keep track of how many you get right and wrong, see how you do with GI. Okay, so for the exam, 4.5% is GI and GU. You're going to get about 2 questions in PT examination, about 3 in differential diagnosis, and about 3 in interventions. And so your total questions for GI and GU are around 8. Okay, so not a huge area, but one that some people are a little weaker on. And I always say some people fail by a small amount or pass by a small amount. And so having as much knowledge going into the exam as you can is helpful. Some people fail by 1 question, right? So we want to get as many right as we can. All right, so let's dig into GI. So I'm going to open the poll. I believe the first thing we have is a polling question. And so I'm going to launch that. Okay. And it's not letting me go to the next slide. Why not? Frozen. Give me a second. Why is it frozen? Whoop. Oh my gosh, it went all the way to the beginning. All right, here we go. Which of the following is most likely to disturb and decrease the normal bacteria in the gut? So we're seeing patients and they're on certain medications, and it can put them at risk for other issues when it disturbs with certain things. So here we've got a medication, and it's disrupting and decreasing the normal bacteria in the gut. And so then we can have other issues. So what medication is that going to be? Okay, so I always wait till we got about 70%, and then I usually close the poll. So nobody said 3 or C, opioids, good, yeah. And nobody said multivitamin, right? You know, I struggle sometimes to think of the other answers. So I'm going to end the poll here. We're between the non-steroidals and the antibiotics. And our answer here is the antibiotics. So our GI system is made of a lot of our body's immune cells, like 70 to 80% of the body's immune cells. And so when somebody, and this is a lot of our patients, right? They're on antibiotics, and maybe they're on several different ones, or they've been on them for a long time. It then starts to decrease the normal bacteria in the gut. And so then they can start having GI issues. And so an infection also can interfere with the nutrients needed for the immune function of the GI tract. So you've got they've got this infection, they're on antibiotics, and now they've got some other GI complications or issues, and that kind of makes sense. Okay, so I'm going to launch the next poll. Okay, let's look at the next question. A physical therapist arrives in a patient's hospital room. The patient reports they had just vomited, and it looks like coffee grounds. So they told you that, or you see it. What is the most important action for you to take? So I'll let you read the answers. All right, so again, we're down to 2 answers, which is good. A lot of students tell me I get down to 2 answers on the exam and I have a hard time picking them. But you guys had it down to C and D. So educate the patient that vomit can sometimes have that appearance. No, the coffee grounds is a red flag. And so we're like, no, that's not normal. Document it, recognizing this is normal in some circumstances. We are going to document it, but again, we're not just going to document it. We need to do something else. So we're going to alert the emergency system, the appropriate emergency system in the hospital? Or are we going to alert the nurse document the information on the patient's chart? So what we're going to do is D. So good job. Most people, that was the majority of who said that, right? So we're going to alert the nurse or call the physician if there's no mention of this in the chart. If we're the first person to recognize this, we need to let somebody know. Maybe the nurse, maybe the physician, could be the resident, and we want to document it, make sure that our note has that in it. So somebody should be reading that as well. So it's not normal. So we got rid of A and B. It's concerning. It does mean that there could potentially be a GI bleed, but it's not probably an emergency unless they're like vomiting large amounts of blood. It's not an emergency situation. So just alerting somebody to get it checked out as soon as they have time is the best thing to do. So when blood mixes with the gastric acids, it gives what they call a coffee ground emesis. If they were vomiting bright red blood, that is a GI bleed. That would be a little bit more concerning. If they have black tarry stools or they see blood in their stools, it means there could be a lower GI bleed. Again, not super concerning. We want it checked out, but not super concerning unless there's large amounts of copious blood that is coming out. So let me ask you guys this, and you can put it in the chat. What lab value maybe should you keep your eyes on in the chart if you think somebody has a GI bleed? What lab value in their medical chart might you want to pay attention to? There can be a couple answers here, but what is something, you know, especially with doing physical therapy? Okay, I think you mean hemoglobin. That's the one I was going for. We can look for their red blood cell count. We can look at their hematocrit, but hemoglobin is really important for me as the PT because if their hemoglobin's too low, I actually shouldn't be doing exercise with them. And I didn't even think about this question until just this moment because my mother-in-law has had low hemoglobin and she went in for a procedure and they ended up keeping her because her hemoglobin was so low and it was going down. And they said, we need to find out if there's a bleed somewhere, because if there is a bleed, you know, we need to figure out where that is. And her hemoglobin was so low that she was not supposed to be exercising. Okay, great. So anytime you have another question, you know, or want me to repeat something, just stop me. And you can put something in chat or unmute. All right, let's look at the next one. A physical therapist is doing a home visit and a client reports they have been having severe diarrhea for the last few days. Which of the following is most concerning to you? All right, so 87% of you said 2, which is B. All right, and so let's take a look at it. What is most concerning? Okay, so yeah, it's a possibility of dehydration. So I'm worried about the amount of trips that they're taking to and from the bathroom, and there is a risk of fatigue with that, and they can you know, with severe diarrhea and dehydration, they can, you know, get fatigued. They can, you know, feel like they really weak, things like that. But I don't, with this scenario, I don't really know anything else about this patient. So I don't know about their physical ability. I don't know, but I am concerned about that. I'm more concerned about the possibility of dehydration, because they can have all kinds of issues with that. And that could end up being a medical emergency where they need to be admitted to the hospital. They need to be put on IV antibiotics. They could have a seizure. Like, there's just all different kinds of things I'm concerned about. The increased likelihood of incontinence. Yeah, they could have incontinence. I don't know if they are or not, but if they have incontinence, they'll have to get themselves cleaned up. Hopefully they can do that. If they can't, then I am concerned about that and them getting ulcers or wounds. But again, I'm more concerned about the dehydration. The increased likelihood of a urinary tract infection. Yeah, that can happen as well. So all of these are possibilities. And I could say, oh, I'm worried about all of these things. But if I had to pick one, which the exam makes you do, I'm most concerned about them having some dehydration. And if that's the case, I need to get them medical attention. Okay, hopefully that one makes sense. Okay, so I'll get the poll going here in a minute. An overweight patient reports a current history of a hiatal hernia. Which of the following would be most appropriate when providing physical therapy? All right, I have about 50% of you. Again, we got it down to 2. That's good. I must not have good distractors on the other 2. That's okay. All right, so we had it down to B and C. So work on abdominal strengthening with sit-ups. We don't want to do that. It increases the pressure inside the abdominal area, and it's going to push on that hiatal hernia. Make sure that PT is scheduled soon after a meal. Everybody got rid of that one too. Yeah, we don't want to do that. So we were down to educate the patient about weight loss, because that might be helpful. That's true. When doing exercises, supine would be preferable. Actually, we don't want to do supine. Okay, so laying them supine for exercise or doing sit-ups all changes the pressure in the abdomen. And because they've got a hernia and heartburn can occur and contents from the stomach can move up, it's just not a good position for PT. So it is true they are overweight. So it is true that weight loss can be helpful for a hiatal hernia. And I know this personally because my brother had an issue with a hiatal hernia. His doctor told him, if you lost some weight, it would really be helpful. My brother lost weight, his hernia went away. And he went back and the doctor said, wow, nobody ever listens to me when I tell them to lose weight. But it actually did take his hernia away. And I think being overweight just, again, puts pressure on that area, which can cause the hernia. All right, so let's talk a little bit about that. So basically, the sphincter becomes enlarged and allows the stomach to pass through the diaphragm into the thoracic cavity. And they do a barium swallow, and you can see that in that right picture. And it kind of shows you, as it lights up, that there's part of the stomach that's being pushed up through there. It can be congenital, so there can be babies or individuals that are born with that issue. But other causes would be trauma, anything that weakens the diaphragm or increases the pressure there. Obviously, it could be like a tumor or something like that, or anything that alters the hiatus. Symptoms, they have heartburn after a meal, especially if they're laying down. They have difficulty in painful swallowing. So sometimes they can't even swallow the food. It actually comes right back up, especially if they're they're not taking small amounts and chewing it really fine, it'll come back up, but it'll be actually painful to swallow. So again, they diagnose it with an ultrasound or barium swallow. They are told to try and lose weight. They can use some antacids and try and control symptoms. They're told to keep, elevate the head of their bed when they're sleeping. And prognosis is good, except they're going to have reoccurrences unless it kind of gets taken care of or treated. So, though I answered B, it made me uncomfortable because I'm not exactly sure how my scope of practice is to recommend weight loss. Can you offer insight? So I think we do that a lot. I think we do talk to people about losing weight a lot. We're not diagnosing anything. We're not saying you have to lose it because of X, Y, and Z, but when somebody comes in and they have knee pain, for example, and they have some severe osteoarthritis and they're very overweight, it is very common for a physical therapist to say, if we could set you up on a good exercise program, if I could refer you to a dietitian, whatever we could do to help you lose weight, losing weight will decrease the pain in your knees. Like we know that being overweight puts a lot of stress on your joints. So we can do that. We do it very tactfully. I think it is within your scope of practice. This one's just true or false. When a patient is taking medications for GERD, you do not have to worry about positioning and activities in PT. Is that true or false? Yep, you guys got it. It's false. So even though they're taking medications for GERD, it doesn't mean we can just do whatever we want, right? We still need to think about the fact that they have GERD and think about what we're doing in PT so that we're not making their issues worse. So let's talk a little bit. Oh, no, I got this one and then we're going to do, oh no, that's the answer. Yes. So, okay. So now I'm going to explain it. So GERD is, so, okay. So I just want to see where we're going. So GERD is the esophageal sphincter is not closing. And so it's not a hernia. It's just that sphincter is not closing. So whatever I ate or drank or whatever's in my stomach, including my stomach acid, because that esophageal sphincter is not closing, it means when I lay down or I do certain activities or whatever, what's in my stomach can come back up, right? And so I can get heartburn. And so the medication helps the symptoms. It helps decrease the acid in my stomach, or it helps with the heartburn. It will not close that esophageal sphincter. So we do need to think about what we're doing in PT. So my next question is, and put this in chat, then what is one consideration when treating somebody with GERD? What is something you want to do or don't want to do? So you can give me a good answer in chat. So I already told you, we don't want to lay somebody flat, right? Completely flat and supine or prone. If they have GERD, especially if they've just eaten or something, it's going to make them worse. Avoid a fatty meal before PT. Yes. Do as many standing interventions. Yes. Yep. If you can do sitting and standing, that's better than laying down. Yep. What else? Anybody else got any more? Those are good. Those are exactly correct. Schedule your appointment prior to meals. Yeah. So, I treat babies a lot, and a lot of babies have GERD. And I'll tell the parent, don't feed them a full bottle before they come into PT, because I don't want their stomach to be full. But with babies, it's a little bit more difficult. So what I tell them is don't bring them in so they're starving, because that's not going to go over well. They're going to scream their head off because they're hungry. So go ahead and feed them, but don't feed them a lot. And maybe feed them like 20 minutes before you come in. Give it some time. Adults are easier, right? We're going to say, hey, let's schedule you before lunch, or make sure you don't stop and drink a big gulp before you come to therapy or something like that, right? Good. Okay, so let's look at the ones I have. You don't want to have that recumbent, avoid jumping movements, perfect. Yeah, you don't want to have that recumbent position of laying down. You want to avoid bending over, right? That's the same thing. As soon as I put my head down, I increase my abdominal pressure, and it's putting my, flipping me upside down, right? I don't want to do that either. We've talked about meals. They do suggest that somebody with GERD, especially if they have severe GERD, remain upright for 3 hours after a meal. Pain decreases with antacids, so that might help them get through PT, but we still need to be thinking about what we're doing. Somebody just said, avoid those jumping, bouncing, jogging type things, because what you're doing is you're just, as soon as somebody jumps, I mean, you've all had that, right? If you've been, working out and you feel the water you just drank in your stomach sloshing around, you probably have. But if your esophageal sphincter is not closing, that water is just going to come right back up, right? So that, and then that acid comes up. You can educate some patients to avoid certain things that are going to increase their symptoms, like caffeine, nicotine, alcohol. Certain medications are going to make their GERD worse. Educate them that they should sleep on their left side at night with their head up at least 6 inches. So if you need to lay them down to do some exercise, make sure just put them in a reclined position. And we want to, say I have somebody in therapy who has GERD and their blood pressure is dropping, and I need to lay them down because they have orthostatic hypotension. I'm going to lay them down, but I'm going to probably elevate them a little bit, and if I can, turn them on their left side. Drinking between meals, they say, is better than drinking with a meal, kind of spreading things out. Walking after eating, they say, is very helpful. So maybe educate them that after you eat, go take a walk. After your lunch at work, so you can get in a quick walk, those types of things. And they should avoid eating before bedtime, right? Because then they're just going to go lay down. So just some things to think about with GERD. All right, so strenuous exercise can be appropriate for those with GERD. True or false? Okay, I got people. I actually don't like this question now that I'm looking at it, because just saying they have GERD, yeah, they can go out and run and do all of those things. I guess it really depends on the amount of GERD that they have. So they do suggest that we are careful with strenuous exercise, and we avoid those bouncing motions. But I do believe this is for somebody who's really having major issues with GERD. So for example, I have a PT friend who said, I have GERD and I go out and run, and I'm like, yeah, but you're also controlling what you eat and you're controlling your GERD, and it's not that bad. But there are some people who have really severe symptoms with it. And so in that case, we would not want to have them running if we could avoid to do that. Also, strenuous exercise does inhibit gastric and small intestine emptying, which can contribute to GERD. But again, if they're exercising at a time not close to when they ate a meal, it would be fine. So I feel like this answer is, it could be true, it could be false. And so reading that, I'm like, I don't really like that question now. So I think I'm going to probably change it to like severe issues with GERD, and then or around a meal time. And then the answer would be no, we wouldn't do that. So when I teach the 2-day therapy ed course, I always take my water bottle and I say, hey, when you have a question about GERD on the exam, I want you to remember my water bottle. Fill that water bottle with water, take the cap off. That signifies your inability to close that esophageal sphincter. And what happens when you lay that water bottle down? Blah, stuff comes up out of the stomach, right? That water signifies whatever's in your stomach. It's going to come up. If that water bottle is full and I squeeze them, what happens? The water comes up. So that, I don't want to squeeze them by doing abdominal work or having them bend over or whatever. I don't want to shake that water bottle. The water comes out, right? So think about that water bottle as you have questions on the exam about GERD. Okay, back to polling. What is the most common cause of severe retching and vomiting as a result of alcohol abuse, eating disorders like bulimia, or viral syndrome? Okay, I've got about 50% of you. No one's saying hiatal hernia. Good, because we already went through that. We didn't talk about that. All right, so looks like most people are saying 4. I'll share it with you. Okay, and let's see. It is actually C. All right, so this is a pathology that honestly, I'm not sure that you would see on the exam, but it is in the PT pathology book for PTs. I teach the GI content, so I just wanted to bring it forward to make sure that you've heard it. But I'm not really sure that this would be entry-level content that would be on the NPTE. But Mallory-Weiss syndrome is when there's a laceration in the lower esophagus that causes bleeding. So they might have that, throwing up blood and stuff like that. It is the most common cause of severe retching and vomiting as a result of alcohol abuse, eating disorders, bulimia, viral infections. So something that has been a constant chronic irritant has started to wear away that mucosal layer in the esophagus, and can be in the stomach as well. And that is what can cause that severe retching and vomiting related to those things. So those were key words in the question. Okay, so not sure that you'll see that one on the exam though. Unlikely. What GI pathology is directly related to cirrhosis of the liver? All right, so I have 73% of you. So go ahead and end the poll. All right, and share the results. All right, so most people said A, and that's correct. Very good. How'd you know that? That's a tough one. So esophageal varices are dilated veins in the lower esophagus, usually occurs when there's portal hypertension, usually cirrhosis of the liver. And there's an issue with, bleeding and then high risk of rebleeding. So although Mallory-Weiss syndrome is or can be related to alcohol abuse, which we just talked about, it's not directly related to cirrhosis of the liver, where the esophageal varices are because of that portal hypertension. So it's more directly related to the cirrhosis of the liver. That's one I'm not sure that would be on the exam either. So, but just want to make sure you heard about it. And that you did good. This is the last one that I'm kind of like, I don't know if you would see it on the exam, but want to make sure that you've heard it. A physical therapist receives a referral to evaluate a newborn infant in the neonatal intensive care unit who's just been diagnosed with a tracheoesophageal fistula. Which of the following is true about this condition? Oh, wow. You guys knew this one. Okay. 100% said 3. All right. Okay. Nice job. I didn't know if you knew what this was. So this is a condition that's congenital. So they're going to hopefully quickly evaluate and diagnose this at birth. Causes unknown. It's fairly common. And it's when the esophagus fails to develop properly, and there's the connection then between the esophagus and the trachea. And so aspiration, right, is a huge issue. And they can have that excessive drooling and the aspiration. Surgery is required. Like they have to do surgery. Otherwise, that it's a fatal condition because the amount of aspiration that they will do every time they're eating, drinking, even swallowing their own saliva. It could be going down into their lungs. So yes. So you probably will never see this unless you are working with a pediatric population or it's just something in somebody's history. Most of the time we're going to hear that they were born with it and they've had surgery, and then we're going to see them. So that's usually what's going to happen. Nice job. All right, which of the following is related to the use of non-steroidal anti-inflammatory drugs? NSAIDs. We need to know this for the exam. All right, awesome. You guys know it. 100% are saying A. Yep, this should have been something your PT program makes sure you know, right? We have a lot of patients on NSAIDs. When they're on an NSAID, they can get gastritis. If they then don't stop taking their NSAID, they continue. And the acid in the stomach and the medication can eat through the wall of the stomach, and then they have peptic ulcers. So very good. Yes. So it's an inflammation. Gastritis is the inflammation of the lining of the stomach. It can be acute or chronic. And you can see aspirin, NSAIDs, but also other things. If they've got a bacterial infection, the H. pylori is a common bacterial infection that can cause issues in our GI system, which you'll see. Autoimmune disorder, anemia, alcohol. And so you can see there's symptoms there. So you can have some pain, loss of appetite, nausea. They would diagnose it with a scope, possibly a biopsy. And the treatment is don't either get rid of the bacteria, like let's give you antibiotics and get rid of that H. pylori bacteria, treat your anemia or your autoimmune disorder or whatever, or avoid the alcohol, aspirin, NSAIDs, right? They don't do that, or something continues, then they can get the ulcer. It breaks through the mucosal lining. And now, and this can occur in the stomach, but also in the duodenum. Also, gastritis and peptic ulcers can be due to stress. So somebody under prolonged or extreme stress, that increases the acid and pepsin in our stomach, and that can cause it as well. So for a peptic ulcer, the pain's a little different. They have the same kind of pain. It's worse pain. It'll come in waves and it'll last a while. And also it can refer. So they can have midline pain in the thoracic spine with radiation to the right upper quadrant. So we could see, with a peptic ulcer, some kind of radiation with that, or radiating pain pattern. So again, if it's the H. pylori, antibiotics are pretty effective. And again, they should avoid certain things and find ways to deal with their stress, or, see somebody for their stress. Prognosis is good unless there's a massive hemorrhage or perforation, and then there could be a high mortality rate because of the loss of blood. All right, so that takes us to some referral stuff. Whenever you're studying for the licensure board and you're going through your review book or what have you, and we talk about an organ that has a referral pattern or a pathology that has a referral pattern, you kind of want to pay attention to that. That will help you differentially diagnose on the exam. So looking at these organs on the left, where would the typical referral pain pattern be matching with the items on the right? So quickly try and do a little matching. You don't need to put anything in chat or the poll. All right, so let's take a look at this. And we don't want to make it harder than it is. So if we know our anatomy of the GI system and what's more superior and what's more inferior, it really just kind of goes right on down. All right, so the esophagus, my pain is going to be higher. So it's going to be usually between the scapula, kind of high up between the scapula. Kind of hard sometimes to determine that between the stomach, because the stomach can be right under the sternum or the mid-thoracic. So those are pretty close. So I don't know if they'll make you distinguish that on the exam unless they give you some other clues, because those are pretty close. The small intestine, though, is going to be further down. That's above the umbilicus. And then the colon is usually under the umbilicus. And so you can kind of say, okay, that belly button is going to be my line, right? Pain above that's probably the small intestine. Pain below that's probably the colon. And then you should know McBurney's point, right? So a third of the way from the ASIS toward the umbilicus, that is McBurney's points. That is going to tell us that maybe their pain is from an appendicitis, okay? So hopefully that will help you a little bit with referral patterns. All right, so let's match these now. So let's talk about cancer to the GI system, and can you match it with the information on the right? So I'll give you a minute to do that. All right, so let's look at these, and then I'll talk to you about what I think may or may not show up on the NPTE. All right, so here's our answers. Esophageal cancer, it's uncommon. Because it's uncommon, I don't think it's as likely to show up on the NPTE. But if you think about it, if somebody has GERD, and because it is related to GERD, but big risk factors are when somebody is a heavy smoker and a heavy drinker. So tobacco and alcohol are big risk factors as well. And if you think about those things, as I'm drinking, I'm smoking, I have GERD and acid, it keeps coming up into my esophagus, that is causing irritation. And a lot of cancers are due to chronic irritation. And so that makes sense that that would be the cause of esophageal cancer. Luckily, it's uncommon. Signs would be issues with swallowing, obviously, right? And again, that pain between the scapula would be a sign of that. Stomach cancer is uncommon. Again, related to gastritis, peptic ulcers, stomach infection. Like, again, that makes sense. If I've got this chronic gastritis, this chronic irritant in my stomach, that could lead to cancer. But again, it's uncommon. Prevention, we know, we've been educated, right? Eat your fruits and vegetables, maintain a healthy weight, limit your salt, your preserved foods. That's going to help with that. So not sure that you really need to know that one that much for the exam. Colorectal cancer, I would know something about that for the exam. It's the second leading cause of cancer deaths in the US. It starts at risk starts at the age of 40. It has a long pre-invasive phase, and it grows slowly. So we might be the first ones that are picking this up when somebody starts talking about, blood in their stool or maybe changes in their bowel habits. Of course, we need to be asking those questions too and doing good reviews of systems and things like that. Maybe they're starting to maybe they've got pain below that umbilicus or some low back pain and things don't make sense. And we start asking the questions, we would want to ask them, have you been, do you get your colonoscopy every year? Have you had a Cologuard? We might want to start asking those questions. Small intestine cancer, I think also is unlikely on the exam. And it's, that really doesn't usually ever arise in the small intestine, it's usually cancer that spreads from adjacent organs. So if they have pancreatic cancer, stomach cancer, it usually will invade into the small intestine. Okay, so colon rectum cancer, I would know something about. Which of the following GI pathology has a 50% mortality rate? Okay, so I'm gonna end the poll. It looks like we're between A and C. Okay, did I share the results? I did not. Let me share the results. There you go. Now you can see. All right, so our answer here is A. So a lot of times people say B. So B is our appendicitis. Appendicitis isn't the same as a ruptured appendix. So an appendicitis is, this is why we get them to the emergency room, because if it does rupture, then it can cause peritonitis. And if they have peritonitis, yes, there's a 50% mortality rate. That's why if we think somebody has an appendicitis, we want them to get to the ER. We want them to have that appendix taken out before it bursts. Obstructive bowel, that can be dangerous. I did have a patient of mine after total joint replacement die from that. So it is dangerous, but it's not as high. So for a simple obstruction, it's pretty low. For a very severe, a more severe obstruction, complicated or strangulated or whatever, it's higher, but it's not to that 50% mortality rate. And then acute diverticulitis also doesn't have that big mortality rate. So not that you need to know mortality rates for the exam, it was just a question for me to get into talking about peritonitis, appendicitis, those types of things. So our peritoneum, that cavity there, I've got it pictured there over on the right, is a sterile environment. When our appendix bursts, it goes into that sterile cavity. And what's in our appendix, right? It's like waste. It's like, ugh, right? And so what can happen is they get this fibropurulent infection that covers the whole interior part of that. And hopefully it gets diagnosed really quickly. They get the person on antibiotics. Sometimes they have to do surgical debridement and drainage. But yeah, it can be very dangerous, especially for an older adult. So again, if we think somebody has an appendicitis, let's get them to the ER. We don't want that appendix to burst, because then they can be put in this situation, which isn't good. All right, name one assessment technique that you as the PT could use to differentially diagnose appendicitis. We would never actually diagnose it, right? We're not going to say you have an appendicitis, right? But it's something we might do and say, hey, I don't know what this is, but I think you need to go to the ER because it could possibly be this, right? So what are the things that we would do for that? If they have a history of appendix bursting, is it common for them to have symptoms later in life similar to a peritonitis? Ooh, that is a really good question, and I do not know the answer to that. So if they've had an appendix burst in the past, could they have symptoms later? I would say probably not later in life. I think in an appendix burst, they're going to treat them. They're going to, make sure that opening, right, from our GI system is not still there, that's going into the peritoneum. They're going to treat them really well with antibiotics. I think once they are treated and everything's good, I don't think that would be coming back, but I would have to look at that. All right, so appendicitis, psoas sign. Forget the name, but tapping on the right lower quadrant of the abdomen. Yep. Okay, McBurney's, right? We already said that, McBurney's. All right, let's take a look at them. There's a lot of them. All right, so abdominal pain accompanied with anorexia, nausea, vomiting, low-grade fever, elevated white cell count, all of that suggests a ruptured appendix. If we think they have appendicitis, right, we could do McBurney's point. It's also called the rebound sign. You're going to push really slow and deep at McBurney's point, and then you're going to let go. A lot of times when you let go and that appendix bounces back, that's when they have more pain. Okay. But I would, even if you push really deep and they're like, oh, that's exactly where it hurts, I'd be like, oh, that's McBurney's point, right? Obturator sign, basically anything that's putting pressure on McBurney's point. So if I passively internally rotate the right hip and flex the hip, and I've got the thigh now squeezing or pushing on that appendix, that can be a sign. Someone said psoas sign, right? So that's passively extending that hip. And that's just going to pull, everything kind of pulls there on the appendix. Pinch and inch, that's just pinching the skin over McBurney's, lifting it, and then releasing it. That is, yes, you could get pain with an appendicitis with that, but it's a test more for the peritonitis, because if they have the peritonitis and they've got that infection all the way through there, that's going to give them pain. I don't know how you say this, Rovsiving sign. I don't know. This is when you palpate the left lower quadrant, but it increases the pain on the right lower quadrant. And this can be a sign of appendicitis. There's also another one, and I can't remember what the name of it is, but it's where they're standing and you have them come up on their toes and then quickly drop onto their heels. Anybody remember what that's called? That is also one for appendicitis, because you're basically like shaking the appendix when they come down onto their heels. I'm forgetting the name of that one. And then anything with intra-abdominal pressure, coughing, laughing, bending over causes pain, you're also kind of thinking of potentially, especially if it's pain in that area, it could be appendicitis. Is there one test that's more commonly used than the other? Most of the time we're using McBurney's. Yeah, that's kind of the gold standard. We're doing pushing in really slow, really deep, letting go. And if there's pain there, we're concerned. So how many tests do you do before referral? You know, if they're complaining about pain there and I do at McBurney's, and, you know, I've ruled out other musculoskeletal stuff, I'm probably sending them to the ER. Yeah, I don't need to do a ton of stuff. I'm better safe than sorry, right? Because that appendix burst. The other thing you could do is call their physician or referring physician and tell them what you see. And if they're not sure, they'll say, well, you know, have them come into me, or they'll probably say send them to the ER. All right, how long should a PT avoid heavy lifting and straining after a patient has had a hernia repair? So they've had a hernia repair, they come in and we're like, oh, you know, because you had that hernia repair, we've got to wait before we do any type of heavy lifting or straining. We need that hernia repair to heal. What's the guideline for that? Yeah, no one's saying 1 to 2 weeks. Yeah, we need longer. We need longer to heal than 1 to 2 weeks, right? And so you may or may not know this, but again, this comes right out of the pathology for PT textbook, and I wanted to make sure you had this kind of little nugget or fact for the NPTE. All right, so looks like we were between 2 and 3, and our answer here is B. And here's the interesting thing, like, a lot of times it's 4 to 6 weeks. It's 4 to 6 weeks after an MI before we can do more than like 70% heart rate max. It's 4 to 6 weeks after hernia repair. There was something else I just saw recently, and it was 4 to 6 weeks. And I was like, oh, 4 to 6 weeks, 4 to 6 weeks, 4 to 6 weeks. So I think that's a good guess on the exam, because I just kind of see that show up again and again. But this is the recommendation for a hernia repair. Now, of course, we're going to do whatever the actual surgeon tells us. But again, this comes out of the PT textbook on pathology that said we should be avoiding this for 4 to 6 weeks. All right, a patient is diagnosed with a sports hernia, or sometimes it's called an athletic hernia, referred to PT. Which muscles would the PT not want to stress because it's going to aggravate the condition? All right, you guys have got great questions. Okay, so we are down between two answers. We're between 3 and 4, or C and D. And our answer here is D. So a sports hernia or athletic hernia is weakness of the posterior wall of the inguinal canal, results in chronic activity-related groin pain. And so adductor contraction, they're using their adductors a lot during sports, starts to create that. It's kind of like it's an overuse type of injury. It creates that shearing force across the pubic symphysis. And so as they continue to do that activity and use those adductors, it's going to cause them pain. All right, nice. Which of the following is due to weakness and pocketing of the intestinal walls that can become infected? I see we got about 5 minutes. I am going to finish. It is being recorded, so you can pick up this tomorrow if you want, or if you want to stay on, you can stay on. So I think we're getting close to the end, and then I have 4 wrap-up questions. Maybe we'll speed up the polling a little bit. Okay. All right, so we're kind of between 1 and 4. So both are related to the pocketing, the weakening and pocketing, but when it becomes infected, it's diverticulitis. Diverticulosis is that pocketing. The weakening of the wall, the pocketing is our diverticulosis. When somebody gets diverticulitis, as you can look at the pictures there, those little pockets, stuff gets stuck in there, right? Feces, food particles, and it becomes inflamed, it becomes infected, and that makes it then diverticulitis. And so now they're going to need antibiotics and things like that. Yep, so that's just what that is. Oops, sorry. Oh, yes, that's it. Markle's test or heel drop test. Yes, for appendicitis. That's it. Markle's. I could never remember that. Markle's test or the heel drop test. Thank you very much. Okay, which of the following is the most common disorder of the GI system and not related to a structural or biochemical abnormality? All right, so we've got 80% of you saying 1 or A, and that's the right one. So irritable bowel is a group of symptoms, very common disorder. About 20% of the US population has irritable bowel, chronic condition, but they can't attribute it. It's called a functional disorder. They can't attribute it to any like abnormality of the bowel, an anatomy change, biochemical. They think it's due, some people just have some visceral hypersensitivity, or maybe some people have some altered GI motor activity, or maybe it's, processing information in the nervous system. They don't really know. So diagnosis, they have to have at least 3 months of abdominal pain. It's relieved by a bowel movement. That would be a key in a question. It's relieved by a bowel movement, and they have to have at least 3 of those other things there, those bloating, distension, all of those types of things. Pain can be steady or intermittent. It's kind of a dull, deep pain with sharp cramps in the morning and after eating. So they have increased pain in the morning and with eating, but decreased pain after a bowel movement. And so a lot of people do have that irritable bowel. Yes, I know the lectures have not made, the recorded lectures haven't made their way to YouTube recently. I've brought that up to them numerous times. And I apologize. It doesn't, I don't know why they're not getting there. I will tell him again tonight. All right. I'm going to speed this up a little bit. Let's look at this together. I'm not going to do the polling. What GI pathology can have joint involvement? All right. So the inflammatory bowel disease and celiac disease can also have joint involvement. And so they could give you some scenario in musculoskeletal, and then talk about the fact that there's a GI issue with that as well. Which of the following are classified as inflammatory bowel diseases? All right. And so this would be our Crohn's disease and ulcerative colitis. So inflammatory bowel really refers to those two, Crohn's and ulcerative colitis. Celiacs, as you know, is, you can't ingest gluten. It causes inflammation. That's its own kind of separate thing. Short gut syndrome, if you've not heard of that, that's when somebody is just born with a shorter intestines, or they have to do a resection of the intestines because of cancer or whatever, and then they're going to have issues with malabsorption. But those aren't classified as inflammatory bowel diseases either. What pathology is an obstruction located at the distal opening of the stomach into the duodenum? All right, so I'll give you the answer. That is a pyloric stenosis. This is congenital. Hopefully it's picked up soon after birth, especially if it's severe, it will be picked up because what's in their stomach is not moving on past their stomach. They don't know, they think it is due to increased maternal gastric secretions related to stress during the 3rd trimester of pregnancy, and it makes that muscle, there's hyperplasia of that muscle, and then it narrows the duodenum. All right, so let's do our last 4 questions. Okay. Which of the following accurately describes the difference between gastritis and peptic ulcers? So we'll do the polling for these last 4. Okay. Most people said it is 2. All right. Yep, that's great. So gastritis is an inflammation of the lining. Peptic ulcer is a break through that lining. Let's look at the other one. They occur in different areas of the GI system. No, they're both in the stomach. One is caused by NSAIDs, the other is caused by the bacteria. They both can be caused by that. It's just that with the gastritis, if they're taking NSAIDs or they have the bacterial infection and nothing is done with it, it just can go on to be peptic ulcer. Both are treated with antibiotics. They may or may not, right? They may not need antibiotics if they don't have the bacterial infection. Maybe it's just control your stress and stop drinking caffeine. One is treated with surgery. The peptic ulcer could potentially be treated with surgery. Gastritis is not, but they're both not automatically treated with antibiotics. All right, nice. Patient arrives at your clinic with the complaint of back pain. Their pain is in the lower thoracic spine and under the sternum. All your tests and measures for musculoskeletal issues are negative. You think the pain might be referred pain. A pathology of which of the following is going to be most likely? Pain in which area, most likely? All right, good job. So again, I think it would be, they would probably give you a little bit more information to kind of narrow it down between A and D, because again, those are very close. But here we are talking about the stomach. Esophagus is a little higher, but again, it's really hard to distinguish. So I think the actual question on the NPTE probably wouldn't even have esophagus. They'd have something else, or they would give you more information that would lead you more to the stomach. Maybe they're going to say the person's been on NSAIDs, and so they're going to lead you to something that's going to be a little bit more discriminatory. But again, this the small intestine is further down above the umbilicus, colon is below the umbilicus, and then we have McBurney's point. All right, a 55-year-old patient being treated for shoulder rotator cuff tear arrives to PT and reports they have been having stomach pain for the last week. With questioning, they admit blood when having a bowel movement and more frequent bowel movements than usual. When they point at the location of pain, you note it is midway between the umbilicus and the pubic symphysis. Which of the following would be your best course of action? All right, perfect. Okay, 93% of you said we want to contact the physician so that there can be a workup for colon rectum cancer, right? So based on the age, the location of pain, the blood with the bowel movements, more frequent bowel movements, all of that is leading us to something might not be right here, right? We're seeing them for their shoulder and they're having all of these things. We might be concerned. We don't ever want to tell a patient that they should make an appointment. We think they have cancer, right? That's scaring the patient. We can't make that diagnosis. Stomach cancer is uncommon. The pain would be higher. It doesn't even make sense. Educate on proper hydration and positioning to manage constipation. Doesn't say they have constipation. And it's not getting me to the root of what's going on or helping them, really helping them. Teach the patient to avoid heavy lifting or straining, as it could be an inguinal hernia, not with blood in the stools. Blood in the stools is telling us something internal, something else is going on. All right, and I believe this is our last one for the evening. The physical therapist is treating a patient with low back pain following a difficult pregnancy and delivery of triplets. The patient tells you they can feel a lump on their stomach. You examine their abdomen and see that lump there in the picture. Which of the following would be most appropriate action to take? Perfect. You guys got it 100%. Nice job. Yeah. It probably most likely is a hernia, no treatments required. I don't know that. I can't say that. So you want to refer them to their primary care physician because it's possible they need a hernia repair. We don't want to do abdominal strengthening. That'll make it worse. And I don't think they have stomach cancer. It's just not even in the right location. So we're not going to do that. Okay, so this is my little GI checkoff list for the NPTE. Everything that's bolded, we've gone through tonight. The things that aren't bolded, I don't know that you really need to know botulism or antibiotic colitis, so those are a few things we didn't go through. We did go through peritonitis, so I could have bolded that one. I didn't. I don't know that you're going to have anything on hemorrhoids. So that's just my little checkoff list for the GI system. If you have our course manual or our big study guide, refer to the GI content there. Again, next week, we have cervical spine CPG, and that'll be our last online office hour before the exam. If you do want to listen to this one again, and they don't, get it up onto our YouTube channel, I have done this one several times, and I do know that one of the previous lectures is on the YouTube channel. Thank you. Have a good evening. I'll stay on in case anybody wants to go over anything or have any other questions. Stay on for a few minutes.